Okay, just a little bit about me, so you know who's speaking to you. I'm here in Chicago, and I have been a clinical health psychologist since 2011, as was mentioned, and I did help establish the first behavioral medicine service at Northwestern University, which is also here in Chicago. I'm happy to report that that has been replicated in many centers across the United States now. So we have GI psychologists embedded in many academic centers, also in private practice. Our field has really grown, but it still remains very small. I'm curious to understand more what the landscape looks like in Canada for these types of services, since I am in a different country and things are different here. I also did start a private practice in Chicago to expand access to this highly specialized care. It was really difficult to see someone like me prior to the private practices starting because you had to be a patient at the academic center. So we really felt a need to push out into the community. I did retire from my associate professor role at Northwestern in 2023 to join the Rome Foundation Research Institute, which is part of maybe if you work in DGBI with IBS and other folks with functional GI conditions, as they were known prior. The Rome Foundation is the organization that comes up with the treatment guidelines and diagnostic criteria for those conditions. I'm also a patient. I have been living with Crohn's disease since 2002 and EOE since about 2016. So I bring a bit of a patient perspective to how I conceptualize things as well. So as was mentioned, these are our learning objectives, and I'll get right into it. We only have 30 minutes, and I really want to make sure that I put a little bit of information out in each of these areas, but each of these topics could be a talk in and of itself. So I hope our Q&A session, we can flesh out a bit more of the details, but I'm going to try to cover a little bit of each of these topics. So GI psychology, if you're not familiar, or gastropsychology as it's also called, is the application of psychological science to the practice of GI health and illness. And it really integrates these 5 areas of psychology from interventional work. We've done a lot of research on applying standard psychological treatments that have been well vetted in psychology, things like cognitive behavioral therapy, acceptance and commitment therapy, mindfulness-based stress reduction, are things that we have since applied to the field of GI disease and how we can leverage the strengths of those treatments in psychology to address the issues we see in patients living with chronic digestive conditions. And I can say at this point, 20 years into it, the issues are pretty universal, despite, our differentiation between organic or functional, this kind of categorization that we've done over the years. We're kind of getting away from that because the struggles that people are experiencing are very similar. So what I talk about, if I'm talking about IBD or IBS or EOE, a lot of these psychological, social, emotional impacts are universal across the conditions. So the brain-gut or brain-gut microbiome axis is a very complex system that uses many parts of the body, but the central pieces that we think about and kind of target in some of our treatments are the autonomic nervous system, the HPA axis, and the superhighway, if you will, between the brain and the gut, the vagus nerve, and how those parts of our brain communicate with the gut. So like 95% of serotonin is located in the gut, for example, not in the brain. And as our understanding of the gut microbiome has really gotten deeper over the last 5 to 10 years, we're really understanding that this is a two-way communication system, and that how our gut microbiome, also our metabolome, is functioning or not functioning, what those profiles of those bacteria and viruses and fungi that live there influence not just how our gut is working, but can also cascade up to the brain and manifest in things such as anxiety symptoms, depression symptoms, even conditions like Parkinson's disease have been implicated. The microbiome has been implicated in conditions like that as well. There are studies in people with IBD, for example, that have, a certain microbiome profile has been identified that have anxiety symptoms that can be better explained by that alteration, that signaling from the gut than any other things that we would typically attribute to anxiety. So we've really tried to pinpoint what part of a IBD patient's anxiety is from the stress and strain of living with the disease, which is obviously an important part of it, but also, you know, if their microbiome is corrected, does the anxiety get better, even though they still live with the stress and strain of the disease? And that is something that has been demonstrated in some studies. So this is an area that is very complex that I could spend an entire hour on, but we can hopefully talk more about if there are questions. So that's stress, right, of living with a chronic digestive condition. This is a very, not complete list, but if I think about the things that people have been talking to me about in the sessions that I've done with them over the years, this is a rough list of what people tend to be talking about, and then obviously individual struggles as well. But it's really a lot to carry and a lot to navigate. And in the US, our healthcare system has become incredibly stressful, more stressful since COVID, if you can believe that. So it is really a challenge, not just to live with the disease and its symptoms, but to get treatment, to navigate insurance, and some of the things, that are a little bit unique to our system here, but also, just getting appointments, waiting on test results. There's a lot of stress that comes along with the management of a chronic condition as well. So in my world, we have three what we call cognitive affective processes. So cognitive meaning thinking, affective meaning emotional, are the three things that tend to come up in our conversations with people and how they're interpreting and experiencing their symptoms and their disease. And those are body hypervigilance, which is how aware am I to what's going on in my body. And when you develop a chronic symptom, it is a protective response for the brain to start paying attention to that. If I have a pain in my knee, I could choose to ignore it, and be like, whatever, I'll power through. But my brain is going to become attuned to that pain because it's interpreting it as something is wrong. And so that can turn into a hypervigilance where it's hard for my brain to not pay attention to things that are going on. And processes like digestion that usually happen in the background become the noise, the volume gets turned up in the brain and it becomes hard for it to ignore. And so that's a hypervigilance that can develop. With that is a symptom-specific anxiety. I think a lot of the anxiety research that we've done in like IBD, for example, is using generalized anxiety measures, which is okay. But I think that a lot of the anxiety that people experience is not this generalized anxiety that you would see in like a DSM-5 diagnosis. This is symptom specific, disease specific. And then as we're, for the purpose of our time today, food related anxiety, people get really anxious about what they eat. And I'm sure you've heard that, in your work as well. It becomes, a very distressing task, daily task to try to find foods that I can eat if I'm living with something that I have noticed that if I eat certain foods, I get sick. And again, that is a very protective kind of primal response that can really, unfortunately, get away from people and get them into tough spots. So these are some ways that, we explain this to folks. My original research was in stigma. I did my dissertation on stigma um, in IBD and got into the weeds of people being concerned about how others are perceiving their experiences and their disease. And so we have to be careful of the language that we use to explain these things so that people don't feel like we're saying, hey, you're sick because you're anxious, or your symptoms are all in your head, which is a common thing we hear from folks with IBS, for example. So these are ways that we explain what's going on. Even using terms like hypervigilance and anxiety can be a turnoff to some patients because they feel like we're psychologizing their physical illness. So these are ways that I will explain these processes instead of using those words. Also, the word anxiety, we use that a lot in our academic pursuits, and it is a word that unfortunately still carries some stigma with it. Mental health is very stigmatized. It's better in 2025, but it's certainly something that people can be sensitive to. So when I talk about anxiety and worry, I always talk about it as a normal and expected response to a problem in the body. And we're also talking about a continuum. We don't want people to not be anxious or worried about a chronic symptom because then they would never seek care. But we also don't want people to be overly anxious. We want to find that happy middle ground. Um, and it's not a psychiatric diagnosis, but the brain is absolutely involved in, trying to um, reverse the dualism that has really defined Western medicine, that the brain and body are separate entities, still persists to this day, but, really educating people that, this is a system, a brain gut system that, we have to include the brain in our conversations. My soapbox today will be that I really think we have to consider the role of medical trauma. Um, in how people are reacting to food and using avoidance behaviors that can look like an ARFID, for example. Um, again, this could be a whole talk on its own. We did a few studies at Northwestern looking at rates of post-traumatic stress disorder symptoms in patients with IBD. We also did a little study in folks with esophageal diseases. This is a very early uh, body of research, but it has picked up some steam in the last few years. And the takeaway from these graphs is that around 20 to 30% of IBD patients will report moderate or higher levels of these symptoms of PTSD. So increased arousal, negative mood, avoidance, and re-experiencing are the four symptom clusters of post-traumatic stress disorder. This doesn't mean that they have post-traumatic stress disorder. You can see around 10%, 11% of women and 4% of men met the full criteria of the DSM-5 for PTSD. So we're really talking more about symptoms of post-traumatic stress disorder that can manifest and look like things like anxiety, and mood changes, and things like that. So uh, if I have one takeaway for you today, please learn about medical trauma and understand how it might be influencing someone's decisions on how they're navigating eating when it comes to their disease, and also how, some of the treatments that we ask for people to do can feel kind of traumatic as well. So ARFID and GI, my co-presenter is also going to get into this quite a bit. So I'm going to, get you kind of lay the foundation for this topic and conversation, and she's going to get into more details once she starts talking in a little bit. But the simple answer that I give when I talk about ARFID is it's very complicated. And there's a lot going on, including trauma, which I don't think has ever been considered in these ARFID studies that we have. So I'm going to present and talk about what we know so far and, where there might be some problems in some of the prevalence data that we've collected. So this little bit busy image is to show it's applying a bit of the stress curve. You may have seen that, in terms of how stress and performance are related. So the point of this is we're looking for people to be operating in this optimal eating behavior zone, if you will. So we don't want them to have high attentional bias to food threats. So folks that, are very rigid and very concerned about what foods they might be eating, maybe on a highly restricted diet because they've tried foods and they subsequently had symptoms, and therefore that's it, that's gone. I can never eat that again. Very strict rules. That's where we get into these avoidance behaviors, hypervigilance, poor quality of life, and anxiety. As we go down, towards the right side of the arrow. And on the left side, we have complacency, which could also be problematic, especially in conditions like celiac disease, where, as far as I understand as a psychologist, it is gluten-free, you know, indefinitely. A gluten-free diet is the treatment. And if I'm complacent about that, I'm going to get exposure to those offending foods, and I may exacerbate my condition and cause damage to my digestive system. So we want people to be operating somewhere in the middle, ideally. And this is going to fluctuate, just like stress and everything else fluctuates, but we want people to be in that box, in that range, if we can. So ARFID, or avoidant restricted food intake disorder, is a condition that is actually in the DSM-5, Diagnostic Statistical Manual for Mental Disorders, 5th edition text revision now that we have. And there are three sub sets of symptoms or reasons for someone to meet the criteria for ARFID. And those are sensory issues, so not liking textures or flavors or things that you might see in children who might be on the autism spectrum, for example, or other sensory concerns. Lack of interest in food and eating. They're too busy doing other things, or they're just not really interested in food. And then fear of aversive consequences or digestive symptoms. And I have fears in red and underlined and bold because that is what is primarily driving ARFID diagnoses in GI patients, logically, right? There are red flags that need to be present for an ARFID diagnosis, so significant weight loss, nutritional deficiency, dependence on some sort of oral or nutritional supplements, and marked interference with psychosocial function. So there's this conversation going on in my field between psychologists of, well, what's normal and what's not? And when should we get concerned? And when should we actually diagnose someone with ARFID? And even if they meet the criteria per a screener, such as the 9-item ARFID scale, which is the most used, and it's validated in the general population, but it hasn't really been well validated in digestive conditions. But that is what has been used with some other questionnaires as well to identify prevalence rates of ARFID. But if I'm sick with the flu, I'm not going to go out and go to a restaurant and eat pizza, or a regular meal, right? I'm going to be eating toast, might be drinking some tea, and that's it. I'm done, right? Why would I put food in my system? I feel terrible. That's fine in an acute situation, but when we get into a chronic situation, you can't really live like that. So we do have to figure out how to eat despite the risk of feeling pretty bad and having this pain and diarrhea. So we look for these red flag symptom issues, as I mentioned, especially significant weight loss, nutritional deficiency, etc. When I'm meeting with someone and I suspect ARFID, my thing that kind of tips me into, yeah, this seems like ARFID, is that very rigid lack of flexibility in trying, a food they may have eliminated, a lack of even concern about how restricted their diet is. Like there's something about the rigidity of it, and just, nope, this is fine. This is working for me. And no, I'm not ever going to try to reintroduce these foods again. It's fine that I need to drink, ensure, there's a feel to it. I'm sorry, I can't come up with more concrete things that when I sit with someone where I'm like, okay, this feels like ARFID to me, versus someone who is afraid to eat, but wants to try to eat, wants to try to, re-diversify their diet. I am less prone to give someone an ARFID diagnosis who is in that side of things, in part because an eating disorder diagnosis is stigmatizing. And I think through what benefit does this have for this patient to have ARFID in their chart? And how is the next physician or provider going to interpret them? And is there any risk in putting that in their record? So I'm a little bit more mindful, and I think that most people fall into that part of how it might look like ARFID, but is it really, versus what I say true ARFID that I've seen. And I'm happy to answer questions about that in the Q&A. So we did a study of 289 patients at Northwestern, and we found, for example, 78% of patients with achalasia met the cutoff, or the criteria on the 9-item ARFID scale. I highly doubt that 78% of patients with achalasia have ARFID, but just using that cutoff and that screener, it way overestimated. Even celiac, half of people with celiac and Crohn's and EOE, at very high rates, way above what we would see even in the general population. And so we looked at it, we're like, well, what is driving this positive, this score? And half of it was explained by the fear subscale. Very few had sensory or lack of interest elevations on those scales. It was the fear. And so then we go, okay, well, yes, people are afraid to eat. Does that mean that they have ARFID? So these screeners, while important and useful, cannot be what you use to diagnose ARFID. There has to be more conversation about what's going on to really understand the nuance of why people are afraid to eat and why they're avoiding food. More recently, I looked in the literature, and we're looking at ranges in a scoping review in DGBI between 13 and 40%, so large ranges, using a different questionnaire, not the NIAS. 18% of 325 IBD patients, the party ARFID subscale, so a bit lower. And then also a population study, so not GI, found 26% screen positive for ARFID. So we're kind of all over the map here, which is common in psychological stuff. In GI, that it's like, is it 13% or is it 40%, or is it somewhere in between? And so we have to look at the literature, a little bit critically about what these numbers mean. One alternative that has not been validated, but I think is a potential, is the fear of food questionnaire that was developed by Hannah Zickgraf, who's really one of the pioneering psychologists in this space at the University of, she's not at Alabama anymore, she has moved, but looking at more specific, and specific to GI disease, not a questionnaire that was developed from a broader population as the NIAS was. In terms of treating ARFID and GI, I wish I was wrong on this, but I only found one study, a true trial, where they looked at 14 patients with DGBIs, and they did 8 sessions of CBT. This is done by Dr. Murray over at Harvard, who is probably the leading psychologist in GI looking at ARFID and other disordered eating. And the good news is that applying CBT in 8 sessions, which is pretty brief, did show large effects in reducing the fear which is that main driver of ARFID symptoms in people with GI disease, and also reduce gastrointestinal specific symptom anxiety. So that is another target that we're going to be able to treat with a CBT tailored for ARFID and GI. And also people were able to gain weight, which was good. So really like positive outcomes from applying CBT specific for ARFID in a small patient sample, but looks good to start. So that's promising. And Jillian will get into more of the treatments as well, including things, that we look to our dietitian colleagues to be able to help with in some ways, like some motivational interviewing and other strategies. Some of the stuff that we do, there is crossover between psychologists and dietitians where you don't need a degree in clinical psychology to teach diaphragmatic breathing, for example. So there's definitely overlap and intersectionality between psychology and dietetics in this space, in part because of resources, wait times, and things like that. We kind of look to each other to do some of the things within our purview of training, obviously, but to be able to deliver some of these things to help folks. Technology will probably be another way to hopefully leverage this as well, to get things out to more people that don't have access to folks like me. Okay. One thing we looked at in patients with IBD in terms of nutrition, we looked at a small cohort of IBD patients, and we found that there wasn't a significant correlation between the severity of ARFID restrictions and micronutrient intake when controlling for total calories. But it was negatively associated with something called food-related quality of life, which is what I want to have my last topic be for our time today. And whenever I've talked about food-related quality of life in the past, people have not really heard of it. And I'm curious if people on today's webinar have heard this term. I think it resides in the research world more than in clinical practice. But a gentleman over in England developed a 29-item scale to assess food-related quality of life, which evaluates the impact of diet, eating behaviors, and food-related anxiety on a person's quality of life. So they're correlated, but they're not the same construct. We're really looking at how is diet, for example, diet use, or just whether it's prescribed or self-directed, affecting this food-related quality of life, which I'll show some examples of how we assess this. So this study we published in 2024 found that people using physician-directed or self-directed diets had the poorest food-related quality of life, with no differences in whether a physician had put them on the diet or they decided to do it themselves. And we also found that people who had consulted with a registered dietitian, whether it was a generalist or someone specializing in digestive conditions, had poorer food-related quality of life than those who had not. So we interpreted that as, this is cross-sectional data, that people who are struggling the most are reaching out for assistance from dietitians on how to navigate these diets that are prescribed to them. And that kind of speaks to, there are so many people out there that are prescribed diets that do not have access to a dietitian. They're kind of winging it. And I think that a lot of people get into trouble, and they kind of develop a fear of food, anxiety, ARFID type stuff, because in part they're trying to navigate a diet without a lot of good support. That's certainly here in the US, while we have GI dietitians, they're kind of centralized in urban areas at academic centers, just like the psychologists are. So these are some ways that food-related quality of life is assessed. The questionnaire has 29 items, so it's pretty comprehensive, but it gets at, making effort to get all the nutrients that I might need. Enjoyment of food and drink has been degraded. I might avoid going out. I restrict my lifestyle. I just really don't enjoy eating. There are questions regarding cost, financial impacts as well. So it's a really thorough assessment. At 29 items, it's probably not the best to be giving in routine clinical practice, but if you wanted to dig deeper with a particular patient, you certainly could use it to start to get it. There is no short form. We have asked Dr. Whalen to do that, but as far as I know, that has not been created yet. They are working on it. So putting it all together as we started out, all of these things are contributing to eating behaviors, and how, the food I'm putting in my body is influenced by my mood, and then also is influencing my microbiome, which may be influencing anxiety symptoms, which may be, exacerbating prior medical trauma, feeding back down into the symptom cycle. And it can get very, very messy. And so we really have to think through why somebody might be struggling with eating, might be looking like they have an eating disorder. Um, especially something like ARFID that has become really popular in GI to identify in recent years. So those cognitive affective processes that are regulated by the brain-gut axis are key players in these eating behaviors. So while ARFID has gotten a lot of attention, we still don't truly understand all the nuance to it. The conversation has gotten way more kind of diversified, and the understanding, I haven't even touched on culture in this talk, so we have to put that layer in as well. You can absolutely use ARFID screeners, but do not use them to make any diagnoses. They're a conversation point for you. Please consider medical trauma, not even having a diagnosis of PTSD, but just those symptoms and how that might be influencing avoidance behaviors. Consider looking at things like food-related quality of life. And if you can find a GI psychologist, we can be valuable members of your interdisciplinary team. I think that's it for me. Thank you very much.